First up is Andrea Denicoff, Head of Clinical Trial Operations for the National Clinical Trials Network. Andrea will talk about their efforts to revise and update the NCI informed consent template in order to meet several goals, including providing trial participants a better understanding of billing issues, precision medicine trials, and other topics. SWOG members and patient advocates have provided input to Andrea and her team, so your voices have been heard in this process. Andrea, thank you for sharing the latest with us.
Thank you. I'm really happy to be here, and congratulations to SWOG for your 60th. Very exciting. As a former oncology research nurse and oncology nurse practitioner, I'm really passionate about always wanting to make a difference for our patients. And I think one way we do that is through having an informed consent document, at least as one small part of the process, and how we have to continually make it better to keep up with the times. Whoops, going the wrong way. Okay, so I have about 10 minutes to speak, so I might go a little fast, but I'd rather there be more time for discussion than me talking. So I'm going to give briefly the highlights of how this new revision started, how we're going around gathering input, and describe briefly some of the sections in the informed consent that we're changing, and then list how we're going to finalize them. So this slide sort of shows how we all talk about informed consent as a process with our patients. Well, it's also a process with our consent template. And back in the late 90s, the original sort of boilerplate was started, and it's been revised over many years. The latest being in 2013, and I'm sure plenty of SWOG members were involved in 2012, where they took the old consent, chunked it into many different sections, and then with patients very actively involved in the entire process, did a real overhaul on it. So that was launched in May of 2013. And then in 2015, after we'd had enough experience with the informed consent, my colleague, Dr. Holly Massett at the NCI and other members of our clinical trials monitoring branch did a compliance review. And actually, Holly's about to submit that for press, so I'm just going to give little sneak peek highlights of that. So the biggest thing I think to see in this slide is that with the new consent template, we did reduce the number of pages, and patients have told us for years that they would like to see shorter consents. The number of paragraphs, the characters per word, also we were able to reduce. And I think those pieces together help to improve the ease of readability, which a higher score indicates greater ease. And while it trended toward easier reading. So I think we have made promising results with the updates. So this very busy slide looks at those chunks of the informed consent document that I talked about. And on the left-hand side, they're the different sections. And then they're in order of the percent correct, meaning how much they closely follow the consent template. And the easier areas, of course, you'd expect to do well, but three that I just highlighted on the bottom, the what are the extra tests section, created problems for authors as well as the sites. What are the study groups? Patients really wanted a little more information in there than our past template had, and some information about how long would you be in the study. And the next click was supposed to highlight two other pieces of data. Oh, there we go. So here's an example where some used the correct text but added lots of extra words, making the section much longer. Another example where they totally went off script but then kept it short. So we wanted to use these to help guide next steps for how we could make it better. In addition to the compliance review, we've had lots of meetings where we've sort of opened up the floor and asked for input. We had a NCTN sort of kickoff meeting in December 2014 where we brought all the groups together, and the newly awarded lead academic participating sites, or LAPs, they provided us a lot of input. ASCO, and I have to give a shout out to Connie Chepanek and the ASCO Community Research Forum, who pulled together an ASCO NCI symposium on clinical trials coverage analysis. And the next bullet really should be a sub-bullet of that. A big result of that came from we were able to get support the CTSU to pilot an effort to conduct national coverage analysis for our trials. And I have to give another shout out to SWOG, really, and especially Casey Dawson, who has been doing it for years. Shout out to Casey. So those of you who don't know what a coverage analysis are, it's a breakdown of the trial and what should be standard of care and billable under insurance, and what is purely research. And with SWOG's leadership in that, we now have all of the 5 NCTN groups having these done through the CTSU. And a shout out to Dr. Larry Regard, I think I saw you over there, and Martha Herring. And they have the CTSU desk here if anybody wants to talk with them about it and understand it more. In addition, I hope many of you heard my NCI colleague Carol Weil yesterday gave an excellent talk on the ethical issues in our precision medicine trials and our informed consents really needing to describe better patient risk associated with genetic profiling. So in terms of the how we're going about this, this is a alphabet soup of the NCI and all our different divisions, but to let everyone know that we're having this thoroughly reviewed. The next list, if the slide will click. It's getting stuck again. Try one more time. Nope. Okay, there we go. A list of lots of people in the community, and especially SWOG. Really thank you to the members, the operations, and the patient advocates gave a phenomenal amount of input. Unfortunately, we are still waiting for a few key folks, especially the Office of Human Research Protections. I was hoping to have come here and told you that it was done, but we're still waiting for their feedback, so it is not done. But what we've done in aligning the coverage analysis that I spoke about, the extra test section was meant to help. Patients wanted us to tell them what was different about maybe being in a trial than what was in standard care. But unfortunately, at the majority of sites, what we heard over and over again is that the billing compliance and research compliance officers would take that consent form and use that as rationale for what was safe to bill and what was not, because everyone's concerned with Medicare fraud. So unfortunately, I'm not sure why the word extra meant research, but it did. So with this review, we've changed that to what exams and tests, and then we've worked with billing compliance officers and many of you to change that language and really separate the section into a clinical exam, what's really appropriate, and what's research. And this aligns directly with the Medicare's coverage of routine costs in clinical trials. And I put the link in there for those that you aren't really aware of it that should. That states, Medicare will cover the clinically appropriate monitoring of the effects of the item or service or the prevention of complications. So when you're writing your protocols, if you put that rationale for why you need that eye exam, why you need that echo at the start because you're preventing cardiac toxicity, that is a clear indication that we'll get can be billable. And then our team at the CTSU and working with Casey and all the other groups will align that. So hopefully when a protocol gets launched, your site won't have somebody, that being a barrier to either activating the trial or your patients getting stuck with the bill. What are the risks? This section had updates, again, regarding the genetic risks. And also, we wanted to make sure that there are risks about waiting for test results and delaying treatment start, because that is happening in a study or two. And then in the cost section, to mirror the new revised, what are the tests that you need, we've clearly divided into your potential costs as a patient and costs paid by the study to better help the patients understand that the insurance will be billed for certain tests, and it should all line up with the coverage analysis. The other thing we heard from a lot of sites is our phase 1 trials have so much preclinical data that our former use of the term unlikely to help was also causing billing problems, because as you know, with the Medicare insurance coverage policy, trials with therapeutic intent do get covered. So we'd like to propose using may or may not help you. I think that helps patients understand that there is a potential for help. However, that is not the primary aim of the trial, but we have seen plenty of phase 1 trials that do have benefit. Again, some additional studies section talk more about biobanking, things that Carol talked about yesterday. And just our feedback thus far from all of you and many others is to really think about having a patient-centered approach when you're writing the consent form. I can imagine it as a PI writing the extremely scientific part of the protocol and then having to switch gears and totally rethink how am I going to talk in a really concise, patient-friendly, non-technical way so patients will understand. And that's what we're trying to have the consent do, but we're going to have better language in our instructions. There have been requests for the NCI that we should mandate, including a patient-friendly study schema and patient-friendly calendars. We haven't ever mandated that, but so I'd like your input on that. And then we've had some really detailed reviews of looking at our language with GCP requirements as well. But lots of people sent in, and I picked one quote. Overall, I think this ICD template is an improvement. I'll keep my fingers crossed that this new template is used thoughtfully, and we certainly hope so too. So the next steps is we are awaiting OHRP for final review, and we also want to do a testing once we put all that language together and then do a real comparison of will we be making it worse than the 2013, because we don't want to sort of think we're making it better and then not. And then try to then collaboratively launch this template working together and rolling it out and making sure that the alignment of the protocol, the informed consent, the funding memo, the coverage analysis, and the consent are all in line saying the same thing. And then we'll all have to work on deciding a future date to begin using the informed consent template, because I realize it's really connected in all your infrastructure. So we'll work on picking a date together with that. And then we will set up a email box so that people could send us regularly feedback on using the consent form, so we can stay more sort of in tune with the community's needs. And again, thank you all for all your feedback.